Good afternoon, ladies and gentlemen. Thank you very much for your participation today. From now on, we would like to start our online conference entitled Japan's Long-Term Care Build from Asia, Promoting Elderly Oral Health, co-hosted by the area and Nagasaki University and the University of Respati, Indonesia. I'm Yoichiro Hiruma, that's from Shizuoka University. Very nice to meet you. And so this is the organized by the area and financed by the Toyota. First of all, we would like to request the professor or director of the University of Respiratory, Professor Toriburi, please.
Good afternoon, ladies and gentlemen. On behalf of Indonesian representatives, I would like to express our gratitude to Professor Hirano from Nagasaki University, who have arranged this international webinar. Dr. Yoichi Hiruma, Shizuoka University, as a chairperson of this international webinar, Professor Michio Yoneko, Reyes University of Shizuoka, for supporting this webinar, Prof. Misako Higashishima, Nishikushima University, Vietnam Research Member, Ms. Tuan Nu Ngo Mai, Ms. Muten Thi Lan Yong, Zeri Cherofer University College of Care Work, Masayuki Chuyisaki from Nan Ai Corp, Vietnam, Yuichi Jack Yuka Magunut Global Corp from the Philippines, Duam the Tu Hong from the Tokyo Health Science University, also for Indonesian researchers from Center for Family and Aging Studies, Universitas Respati Indonesia, Susyana Nugraha, Biben, and Lisna. And especially, I would like to express our gratitude to Dr. Sudibyo Alimusho as the Director of Center for Family and Aging Studies, Universitas Respati Indonesia. We would like to welcome to representative of the Ministry of Health Republic Indonesia, Ministry of Social Affairs, National Board for Migrant Care and Placement, and National Board for Demographic and Family Planning, and Indonesian we call PKKBN. Driven by the growing aging population, migration of skilled health professionals from developing to developed nation has increased dramatically, as we know, in recent years and become a preeminent issue in global health. Migration of health workers to developed countries such as Japan is expected to contribute to improving long-term care skills for the elderly in the migrants' home countries by developing the concept of brain circulation. I would like to express my gratitude to Professor Hirano for inviting us, researchers from Center for Family and Aging Studies, Universitas Respati Indonesia, to collaborate in carrying our various research related to brain circulation from Japan to Indonesia as a benefit of care. I also would like to express our gratitude and also our understanding in the meantime that we conduct research on oral care as part of long-term care, adopting the Japanese long-term care on oral care as part of long-term care, adopting Japanese long-term care system. Thank you very much to Economic Research Institute for Asia and East Asia for fully supporting and facilitating this research totally. This research is very useful to improve the quality of care for the elderly in Indonesia, especially in long-term care facilities and communities. Through this research, we succeeded in compiling a module for oral care in Indonesia based on the evidence in the field that we found. Later, this module will be a complement that improve the quality of the existing long-term care modules. Hopefully, what we do can be example for other countries in adopting long-term care system from developed countries like Japan, and especially for Indonesia, we adapted that relate with our local situation. Again, thank you very much to all of you for your contribution on this webinar, and please enjoy the entire program. Thank you.
Professor Trivedi, thank you very much for your speech.
And next, I would like to introduce one other gentleman from area, Mr. Kato of area. Well, I am Kato, and pleased to meet you. And so let me greet to you in English.
Good afternoon, good morning, or good evening. I'm Takuma Kato, a director for healthcare and long-term care policy in area Economic Research Institute for ASEAN and East Asia. As a supporter of this conference, I'd like to express my great appreciation for your participation even under the COVID-19 pandemic. I'm delighted to be able to support today's online conference, Japan's Long-Term Care Viewed from Asia, co-organized by Nagasaki University and University of Respati, Indonesia. AREA was established in 2008 as an international organization that has a similar mission to that of OECD in East Asia. Healthcare unit in AREA has started since 2017, so we are a rather young organization, but since the start of the healthcare unit, we have been conducting various research focusing on the aging issues in Asia. And I believe this project between Nagasaki University and the University of Respati has achieved a great deal in this field of long-term care in Japan and Indonesia and other Asian countries under our research program. Today, I'm very much looking forward to listening to the presentation focusing on oral health, which is becoming more and more important in our aging societies. I would say it will be difficult to create a healthy aging society without good oral health. I hope that today's conference will be informative and enjoyable for you. Thank you very much.
Thank you very much, Mr. Kato. Everybody, thank you very much for your speech. So, we would like to start part 1, which is about the mid-term report of area study 2. First, I would like to invite Professor Hirano from Nagasaki University. Professor, Hirano, the floor is yours. Good afternoon, everyone. I'm Hirano, professor at Nagasaki University and the organizer of this event. Thank you very much for your time to participate today. First off, I will briefly walk you through how our research at the area has progressed and the research outcome as well. First of all, prior to this event, I would like to share with you the views of the organizers on the use of the terminology. First of all, the term kaigo or care. So first of all, that kaigo or care is defined as the providing physical and psychological and social support to people who are experiencing some kind of difficulty in their daily lives so that they can lead high quality daily lives regardless of who is responsible for the care, whether it's care professionals or the family caregivers. And next is the concept of the jiritsu-shien or self-reliance support. This is defined as physical and psychological and social support extended by care workers to enable the care receivers to lead daily lives by utilizing their remaining function to the fullest. And kaigo shokusha in Japan, the term, this is a care worker that is used neutrally to mean a person who is engaged in nursing care in care, as there are both qualified and unqualified care workers. So in Indonesia, the term caregiver is used, and also the different terms are used in different countries. So these are concepts that are used in the context of the Japan's long-term care insurance system, and there is a debate that the concept should be marshaled. It might be fair to say that the different people have different definitions. Therefore, it was very difficult to logically translate it into English. So for this reason, even in the presentation you are about to watch, the translation has not been unified. Please understand that this is because each speaker's perception is reflected in the translation. Part of the characteristics of the Japanese culture of ambiguity might be manifested in this state. In the future, we will have a separate discussion on what supporting the care receivers to be independent means, but I hope you will consider that the oral and swallowing care that our research group will focus on this time is how the care workers can support the act of chewing, swallowing, taking in nutrition, and enjoying meals using the remaining function of the body until the end of their life without relying on the gastric bandages. Today, there has been a move to bring foreign care workers to Japan through various channels, such as technical interns or foreign workers equipped with special skills and nursing students. There is a serious shortage of nursing care workers in Japan, and addressing this shortage is an imminent issue. However, when I looked at foreign nationals who came to Japan through EPA or bilateral economic partnership agreement scheme ahead of these people and are working in the nursing care field, it came to our attention that a certain percentage of them still return to their home countries, even though they have passed the national exam for care workers and are qualified to live in Japan as long as they work as care workers. And the ratio of those to return their home countries differ from country to country, but anyway, it's said to be about the 20 to 40%. And the trainees are supposed to return their home countries when the term ends, and the part of them shifted to those with the special skills scheme continue to stay, but the rest are due to return. So therefore, the number of foreign workers who temporarily stay in Japan and eventually go back to home countries are sure to increase. So furthermore, in this globalized society, Japanese who worked as care workers might go and join the workforce of foreign countries. So therefore, I think we have to think beyond the imminent challenge of the securing care workers for Japan because of the serious shortage of the workforce. From now on, our view has to be predicated on the fact that the competition over care workers will further intensify globally, and we must win in this fierce competition. And to this end, Japan has to expand our presence. So in this way, I believe the long-term perspective on sustainability of the entire long-term care industry is needed. So there are various reasons for the foreigners to returning home countries eventually, which are beyond the scope of this project. So I would like to discuss them some other time. However, if a certain percentage of people who come to Japan return to their home countries, I thought it would be nice to have them contribute to Asia, where the population is aging in some form or another, with their experience working in Japan. And I thought it can be a form of international contribution and also the way of the increasing the Japan's presence. So for this reason, I started this research from the perspective of whether it is possible for Japan to transfer skills to Asia in this field. Now I would like to introduce our research members. So we are in an international collaborative research team consisting of a team from Japan and Indonesia. Our research team is characterized by a blend of disciplines of humanities and science, consisting of the clinicians and the social scientists. As the principal investigator, I myself am a sociologist with a degree in health science, so I have an identity in both in humanities and the sciences. Since we will be examining techniques of care across different societies and cultures, it is essential that not only clinicians but also cultural anthropologists and other humanities researchers participate. Here, I would like to introduce what we have done so far and why we have paid attention to the oral care. In Area Study 1, we decided to compare the way the care is provided in Indonesia and Japan, how the oral care is provided in both countries. So that there are many different types of care given to the elderly. Therefore, we focused on oral swallowing care. This is because it is the most invasive of the three major activities requiring care, which is bathing and toileting and eating, and poses a risk of choking and aspiration for those who need care. In addition, the act of eating is important to maintain the quality of life after we advance in our age. The physiological reflexes of chewing and swallowing are based on anatomical and physiological structures common to all humans and are therefore the least susceptible to cultural influences. So I thought it's easy to create a universal model when we develop this scheme or the framework. The study 1 was implemented in 3 steps. In the first step, Japanese and Indonesian researchers visited the long-term care facilities for the care receivers to observe and film videos of them eating. In the second step, both Japanese and Indonesian researchers carefully observed the recorded videos of the meal scenes and discussed the necessity and the current status of care related to eating and swallowing. Based on this discussion, we developed an Indonesian version of the oral care checklist. At this time, we used the oral swallowing care checklist developed by Dr. Higashishima and Dr. Watanabe at this time as a basis for our work. There were 92 items in total originally. In light of the current situation in Indonesia, we examined the items that existed in Japan but not in Indonesia and which were considered to be the minimum requirements in Indonesia one by one to see if they could be included in the list or not. And the next, as a third step, we conducted the survey with the Indonesians who were working as caregivers in Indonesia and those who were working as care workers in Japan by asking them to answer the questions on the oral care checklist and made a quantitative comparison of the level of care. practices in Japan and Indonesia. At this time, by using the same Indonesians as subjects, not Japanese, it is possible to control the differences in the environment of care between Japan and Indonesia. This is the second stage of work to create an oral care checklist. We are watching videos of meals at public elderly care facilities in Indonesia.
オラルケアのチェックリストの項目をですね、
and discussing them with Japanese and Indonesian researchers and clinicians from various interdisciplinary fields. At this time, we have done some adjustment. For example, we removed a question item from the Japanese version, which is if there are tableware or eating utensils adjustable to the levels of the individual's disability, since this item is clearly not available in Indonesia, so we removed it from the checklist. Another example of an item that has been revised to reflect the current situation in Indonesia is whether there is a means of communication such as a bell for a caregiver or a care receiver to notify another caregiver of an emergency, and we modified it accordingly.
過ぎてますね。
I'm sorry, I'm moving too fast.
オラルケアチェックリスト合計41
So
項目
there are 42 items for the oral checklist.
メインからなります
This is a finalized oral care checklist. These are divided into 6 domains, and the reliability and the validity of this checklist has been scientifically examined. And then in the third step, we conducted a survey of the Indonesians, but EPA caregivers in Japan, 110 people in total, and Indonesian caregivers in Indonesia who are providing care to the caregiver receivers, 213 people in total. In the survey, we asked them, when you usually provide oral swallowing care, do you or do you not conduct each assessment item of the 42 items on the checklist on the previous slide? We then scored the result in this graph. Interestingly, the results showed that Indonesian caregivers in Japan were more likely to implement the assessment of the eating environment, feeding period, and post-meal period.
ことが分かりました。一方、
But the assessment of the overall full body condition was scored higher by the caregivers in Indonesia.
このことから、
So this indicates that Indonesians living in Japan have better facilities and safer meal care under Japan's long-term care insurance system, which is also complemented by the brushing teeth properly after meals. However, on the other hand, Indonesia has more caregivers, and they are able to check the full body conditions of each elderly person more carefully.
はい、これまでの研究の内容をまとめて
So now I would like to summarize the content of our research so far.
の内容は
Since the content of care or kaigo varies from culture to culture, the oral care checklist developed in Japan can only be used in Indonesia if it is carefully modified to fit the Indonesian context of care. It also became apparent that Indonesia and Japan have their own advantages regarding care. Caregiving in Japan involves the use of various machines, tools, and techniques, while in Indonesia, a larger number of caregivers are able to spend ample time on a single person who needs care.
今後は
In the future,
ケアチェックリスト
we will clarify the effectiveness of the system by following the developed oral care list and developing modules, running them, and measuring their effectiveness. So that Dr. Higashishima and Mrs. Shiana are to make presentations on this. That's all from me. Thank you very much for your kind attention.
Thank you very much, Professor Hirano. And now I would like to call upon Professor Misako Higashijima from the Nishi Kyushu University. And Professor Higashijima, you have the screen. Now, so I would like to report on the research result in a sense. And I would like to talk about the developing an oral care module for Indonesian caregivers, which is based on the clinical study. And I am Higashijima of Nishi Kyushu University, and it is my pleasure to talk with you. Oh, I have already explained this slide. Okay. Well, now I would like to, to introduce the flow of the study. So I would I will talk about the two ways of collecting information on Indonesian elderly patients. And next, so I'll discuss the results of the analysis of the two types of information. And finally, so I'll discuss the purpose and features of developing an Indonesian version of the oral care module based on the analysis. Well, in this research, 11 research members watched videos of elderly Indonesian patients so having a meal. So 11 research members versus 11 patients. As we watched the videos, we checked off items that we thought were problems. Out of 28 items, we checked off 3 items during the meal preparation period, 8 during the feeding period, 13 during the swallowing period, and 4 during the post-meal period. And each member checked off items which they thought would be of problems. And next, the 11, so we checked the physical, mental, and swallowing functions of 11 Indonesian elderly patients. And so we conducted the 3 tests shown on the slides. And these are the tests in which elderly patients respond to questions asked by the examiner. So first, Hopkins Verbal Learning Test is a test to determine the degree of dementia. EAT-10 is a test to determine the swallowing function. And Barthol Index is to determine the status of activities of daily living. So we conducted these 3 studies. So the specific methods and criteria are shown in this slide. Well, the previous slide showed the 3 tests. They were based on interviews. But the 5 tests shown in this slide are the actual tests to be performed on elderly patients. So we asked the patients to do a certain motion. And first, there were the seating ability test to see the stability and endurance of sitting while eating. And so we also conducted the phonatory test to estimate the swallowing apnea time. And we also conducted the party horn test to estimate the duration of exhalation. And in addition, we conducted the upper and lower extremities function test to check the degree of motor analysis of both upper and lower limbs of the elderly. So the 3 tests in the previous slide and 5 tests, altogether there are 8 tests. So these 8 tests are essential for examining functions for safe eating. So the results of the video analysis of the elderly having a meal showed that among the 28 items, there was a significant difference in 1 item during the feeding period and 3 items during the swallowing period, as shown on this slide. So members of the studies were 3 certified care workers and 4 occupational therapists and 4 registered nurses. So as it turned out that the nurses were the most rigorous observers among the 3 professionals. And there are 4 patients with dementia and 7 patients with strokes. And there are the results of physical, mental, and swallowing tests of the total of 11 elderly Indonesian patients. So we have run among the 8 tests, and among them, the significant difference between patients with dementia and those with stroke was found only in the Hopkins verbal learning test, which looks at the degree of cognition. However, we did not have almost no difference in the test score between the 2 groups, although it was expected due to the difference in the number of samples by disease group. So based on the results of the video analysis of the elderly patients having a meal and the results of the physical, mental, and swallowing function tests, the features for developing an Indonesian version of the oral care module are summarized as shown in this slide. So 9 features are found in the 5 periods of the meal process. So of the before meal period, the meal preparation period, feeding period, swallowing period, and post-meal period. 1 from before meal period, and 3 from a feeding period, and swallowing period. 3 from swallowing period, and 1 from post-meal period. And the slide summarizes the purpose of the items checked in this study. Well, the specific methodology of conducting these studies for the 9 items has been modified for the Indonesian version, mainly based on the book Preventing Aspiration Pneumonia of the Elderly Person, which is shown in this slide. And later, Dr. Susiana will explain about it. So that's it from me, and thank you very much for your kind attention.
Higashishima Sensei, thank you very much. Now, we would like to invite Professor Susiana from the Elisabeth University of Indonesia. Professor Susiana, please.
Good afternoon, ladies and gentlemen. My name is Susiana Nugraha. I'm from the Center for Family and Aging Study, University of Respati, Indonesia. First of all, I would like to thank to Professor Hiruma for being chairperson of this webinar, and also Professor Hirano and Professor Tributi and also Dr. Sudibyo Alimusa for giving me an opportunity to presenting our scientific experience on the development of oral care module for Indonesian elderly caregivers. Here is our research member. I think it's already presented by Professor Hirano earlier. And the background of the study is based on our result in previous study, which is in 2018, in the need assessment of oral care in long-term care institution in Indonesia. It was shown that there are inappropriate understanding of the caregiver in nursing home about the importance of implementing oral care services. An education program is needed to increase the understanding of the importance of caregiver in taking care of the elderly. For that purpose, we developed a module for oral care training program addressed to the caregiver who taking care of the elderly in long-term care facility and at home-based care in Indonesia. Why we choose oral care? Oral care affecting the entire health of the elderly. Several studies identified the statistically significant association between poor oral health with aspiration pneumonia, coronary heart disease, metabolic syndrome, as well as reducing the quality of life of older person. While in Indonesia, the oral care services is still focusing only on dental hygiene, offer the prevention of aspiration pneumonia. The process of compiling the model, the oral care module, is not only translating book to Indonesian version, but also adapting it according to the care need and sociocultural condition of elderly in Indonesia. And the model adaptation process is starting from 2018. Prior to adapt the model, we conduct a preliminary study called need assessment for oral care in long-term care facilities in Indonesia. And then we continued in November 2019. We conduct a field work based on the need assessment study to figure out the oral care services application in Indonesia according to the condition of the elderly. In January 2020, we developed oral care module with Japanese scholar in Japan, and expecting into October 2021, we will conduct an intervention study based on the developed model. And by next year, we will finish this entire study process with the research dissemination. I think it's already explained by Higashijima Sensei. We conduct instrument adaptation prior to the field data collection, and we conduct instrument adaptation instructed by Japanese scholar. Although it is not pandemic yet, but we have used teleconference between Indonesian scholar and Japanese scholar. So we measure several categories, several criteria for measuring functional capacity of the elderly. Let's skip this. And the study participant was selected based on this following condition: dementia and stroke, who is living in community and long-term care facilities. Those who live in long-term care facilities are divided into two categories: private long-term care facility and the public long-term care facility, which means that managed by the government. Here is our fieldwork research member prior to access the elderly. We conduct a briefing while waiting for the elderly, ready for interaction with the visitor during data collection. And I'm going to share with you the experience of challenging of collecting data on the elderly with dementia. These two subjects are older persons with dementia, which mainly difficult to communicate with the researcher. And we have to patiently wait, give them instruction and repeat it several times. During the meal session, the subject suddenly changed their mood and refused to finish their meal. Hence, the researchers need to wait until their mood are returned and being normal. Otherwise, we need to change the subject. So it's kind of harder to collect data with the elderly with dementia. The entire process are recorded in videotape for functional assessment until the meal period. And elderly with stroke are mainly able to cooperate with the instruction of the researchers. Most of them are in disability condition. Therefore, several assessments are unable to be performed, like Bramstorp test and some other tests. And we need to pay special attention, especially during the meal period, for any choking or aspiration or dysphagia. Although they have stroke and disability, these elderly are trained to be independent and utilizing their remaining functional capacities. Each footage obtained from the fieldwork are observed by the researcher in 3 days workshop between Indonesian and Japanese scholar using observation checklist based on Higashijima oral care module. Based on the footage, the team developed the guideline item to be included in the oral care module. And we modified some picture from the Higashijima Sensei's book using Indonesian figure to make the module easier to accept and adopt by the Indonesian work environment. Okay. Finally, we identified several items of oral care practices based on the situation in Indonesia and the result from the observation and footage prior to develop the module. And this is our oral care module developed by Indonesian and Japanese researcher based on the real situation of Indonesia. So we not only adapting the book to Indonesian version, but also adjusted with the Indonesian environment and sociocultural background. And we expect to conduct intervention study next month, next October. It will refer to a training program for the elderly oral care, address the elderly caregiver in long-term care facilities. Based on this training program, we will evaluate the effectivity of oral care module in improving the oral care skill in among Indonesian elderly caregiver. This study is using crossover design conducted for Indonesian caregiver in long-term care facilities. At the conclusion, the oral care module was adopted from the handbook used in Japan and adapted to the condition and culture of Indonesian community. The module application will be tested through an intervention study with a crossover design approach. Intervention study will be conducted on October 2020, considering the pandemic situation in Indonesia. We hope that the pandemic situation will be much better by next month so that we can conduct the intervention study in the field work. Thank you very much for your kindness attention and have a good day.
Thank you very much, Susiana Sensei. And now, I would like to call upon the next presenter from IMC, Dr. Lisna Agustina. And good afternoon, everyone. And first, and I would like to express my sincere appreciation to Professor Hirano and Dr. Suryo Adiosho and Dr. Susiana, who led the area study. Well, I'd like to share my experience with you working in Japan as a care worker. Please let me introduce myself first. I am Lisna Agustina, and I'm teaching at the STIKES, Advanced Indonesian College of Health Sciences, and I'm IMC Bintaro. It is my great pleasure to talk to you. So in 2008, I was one of the first batch of the care worker candidates to enter Japan through a program under the Economic Partnership Agreement jointly run by the National Agency for the Protection and Placement of International Migrant Workers of Indonesia and the Ministry of Health, Labor and Welfare of Japan. One of the challenges when I worked in Japan as a care worker is the language. Japanese is very difficult for me. And when I tried to communicate with the care receivers, I had trouble understanding them as they often talked in Japanese dialects. And also, culture of care was also different. So when I interviewed some EPA care worker candidates for the area study, I was surprised to learn that there was a division of work between the nurse and the care worker in Japan. While the nurse provides medical care, the care worker does not provide any medical care in Japan. The care worker assists a care receiver with their ADLs, activity of daily living. So the care worker provides services to support the daily life of care receivers from the time they wake up to the time they go to bed. So that was very surprising to me. So having worked as a care worker in Japan, I thought I found 8 things that can be applied in Indonesia. So as a care worker in Japan, I was impressed with such phrases as assisting independent daily life and maximizing the residual function of the care receiver, and oral exercise, and the bathing assistance, and the meal assistance, and the mobility assistance, and dementia care. So, so I was most impressed with the phrases as assisting independent daily life and maximizing the residual functions of the care receiver. In Indonesia, almost all the personal care for the elderly is given by the family. This is because people still do not understand the meaning of assisting in independent daily life or maximizing the residual functions. I saw oral exercise for the first time in Japan. At first, I wondered if there was any meaning to it, but then I found that those exercises stimulate saliva secretion and help prevent aspiration pneumonia by the elderly. Of course, I learned oral care in Indonesia when I was in nursing college, but not about oral care for care receivers who have full or partial dentures until I come to Japan. As for bathing assistance, I saw special bath and various mechanical devices used in Japan for the first time. So the care receivers were able to get into the bathtub, warmed up their bodies safely and securely, and became very clean. In meal assistance, I also learned how to assist people with right and left spatial neglect or visual impairments. And in order to prevent aspiration pneumonia, I learned how to use gelatin or thickener depending on the care receiver's ability to swallow. And I saw different types of tableware and food utensils depending on the care receiver's condition. So I also learned about tube feeding through a gastric fistula. In providing mobility assistance, I think it is very important to think about body mechanics in addition to how to transfer the care receiver. As for dementia care, at first I thought dementia and schizophrenia were the same thing. But after learning a lot about dementia care, I have come to understand the difference between the two. So there are some tools that I would like to use to practice in Indonesia. So there are 8 things I want to apply in Indonesia. For example, the bathing machines, oral care tools, and tableware and utensils especially designed for the conditions of the elderly. With this kind of forum, I would like to spread the proper way of caring for the elderly to the society so that the Indonesian government can focus on the advancement of techniques required for a long-term nursing care. I would also like to help promote the development of facilities to support the care of the elderly, such as a good nursing home, fully equipped with bathing, dining, and other facilities like those in Japan, in order to improve the quality of life of the elderly in Indonesia. Thank you very much for your kind attention.
Professor Lister, thank you very much. Now I would like to invite Mr. Bevin from the Dhammavsada Bandhan Institute of Health. Mr. Bevin, please.
Thank you. Well, thank you for this big opportunity. It is an honor for me. First, let me introduce myself. My name is Biben. I was working in Japan as a nurse through EPA program in the first batch on 2008. On this occasion, I will explain the differences of social and cultural in terms of caring for the elderly between Japan and Indonesia. As we know that these two countries have different cultural and demographic backgrounds. Indonesia consists of 17,000 islands and 1,340 tribes that are very diverse, while Japan is not that much. This ethnic diversity in Indonesia greatly affects the cultural values, belief, and habit of social life of the people. In the order of social life, especially regarding the pattern of care for the elderly, it is quite different between Japan and Indonesia. In Indonesia, the elderly, live mostly with their families. This is what makes the pattern of the elderly care in Indonesia still use the family-based care approach. Meanwhile, the family plays an important role to provide care for the elderly at home because the family is the one who in daily activities is very close and easy for the elderly to trust. But in Japan, many elderly people do not live with their families because of many reasons. Many elderly people live alone at home or live in nursing home. Indonesian people still think that living in nursing home is the last decision if there is no one of family can take care of them. Besides that, in Indonesia, there is a stigma that entrusting the elderly to a nursing home is an unethical attitude, so that people consider it is a sin. In the belief of Indonesian people, the family, especially their children, must take care of and love their parents until the end of their life. But in Japan, because most of the elderly have no family to take care of them, many elderly people in Japan live in nursing home. Indonesian nursing homes are mostly managed by social services, and many of the conditions are not suitable for the elderly to live on. And the concept of the nursing home is still simple and traditional. In Japan, nursing homes are very advanced with modern facilities and tools, an organized system, trained and professional human resources, so that the level of feasibility and comfort is much better than in Indonesia. In Indonesia, there are still many people who have not carried out the healthy life. Eating pattern and menus of food are still not according with the need of the elderly because Indonesian elderly live with their families. The food menu allow the menu with eaten by family members. So, even though these elderly have degenerative disease such as hypertension, when family eat a menu such as salted fish or food that contain high salt, there is no other choice for the elderly to eat the same menu. So it makes the hypertension cannot be controlled properly, and it becomes dangerous for the elderly. And this habit, eating salted fish for Indonesian, has been passed down from generation to generation. As long as I live in Japan, it seems that the Japanese lifestyle has become more organized, especially their food is more healthier. Most Indonesian elderly use their hand directly or use an ordinary spoon when they eat. When the condition of the elderly hands are shaking like this, it be it can be very difficult to put the food into his mouth. In Japan, technology has more advanced. There are so many types of eating aids that can be used by the elderly. Carry out the rest of their life, Indonesian elderly more focus on spiritual activities. This activity is expected can make the elderly feel happier and have a better quality of life. Besides that, many of elderly taking care of their grandchildren. Of course, while the father and the mother of the child go to work. From one side, maybe we think that it is very difficult for elderly because taking care of children is not easy and can make the elderly tired. But the other hand, parenting activities or playing with grandchildren can eliminate boredom due to lack of activity in the elderly. Playing with grandchildren is fun for most the elderly. So this can make the elderly's happiness index being increased. In Japan, because most uh, most of elderly live alone, although they will need activities and need a companion at home, so many Japanese elderly keep pets. Even robots are made that resemble certain animal and can interact with them. During the COVID-19 pandemic, caring effort for the elderly must be continued. To make it happen, I joined with the IRL, non-profit organization that work for elderly welfare, which initiated by Miss Susiana Nugraha. I'm joining with this effort to support the elderly, especially during the pandemic COVID-19, based on my knowledge and experiences which I've learned in Japan. Even though there is a COVID-19 pandemic, we continue our activities for the elderly. We are doing the home visit, doing blood pressure check, giving masks and vitamin, and giving special milk to our fostered elderly group. In addition, to improve and provide direction related to health education, dissemination of prevention COVID-19 transmission and vaccine, we, IRL, conduct elderly school activities both offline and online. And from that activities, finally, we received Healthy Aging Prize for Asian Innovation Award in 2021. This pandemic has not stopped us from continuing to move and innovate in giving attention, especially in the health sector to the elderly. Recently, I created a new program called Online Elderly School Series as a result of collaboration between IRL and NurseBiz. Actually, at first, this program was to attract the existing IRL elderly school participants, but because of the interest from the other community outside from West Java, finally, I opened this program for the elderly throughout Indonesia with the hope that through this program, we can provide benefit for the Indonesian elderly. And another hope is I can learn more about the elderly in Japan. Maybe becoming an expert in the field of elderly health, elderly nursing, then I wish I can get opportunity to continue the PhD program in Japan. Okay. Actually, there are so many differences between Indonesian culture and Japanese. But however, because time is limited, I will highlight the differences between Japan and Indonesia. Due to the social difference in terms of elderly care between Japan and Indonesia, in Indonesia, caring for the elderly use the family-based care approach. Meanwhile, Japan is more about nursing home-based approach. Maybe that's all that what I can explain. Thank you very much for your attention. Domo arigatou gozaimashita.
Vivian-san, thank you very much. Now, so the session one presentations have all been completed. So shall we